إيه. انتوا سامعيني دكتور
سامعينك
محمد؟
دكتور محمود.
سامعين.
اوكي، انتوا لسه ما بديتوا انتوا؟ مش عارف.
لا
استنوا.
لسه دكتور. لا احنا
بدي اقول
بننتظر
سكت.
شوي.
انا رحت صليت المغرب بسرعه. خطفت
الله
رجلي.
نحن صلينا العشاء اخي محمود، نحن صلينا
والله شو
العشاء.
اسوي؟
والله والله.
الله، احنا لسه المغرب يا دوبك، خايف يروح علي يا دكتور. بعدين ربنا
نعم.
بحاسبنا.
انا كنت
تقبل الله.
بالشام والله، كان العشاء بيأذن شيء 9، ما هيك؟
9 يعني 9 وثلث. 9 وثلث
نعم
والله.
9. نعم
9 وربع 9 وثلث. الحمد لله. يلا ان شاء الله خير. الاسبوع هذا انا رايح على ليبيا، ادعي لنا.
عم بسألهم والله هلا كنت، يلا بالسلامة ان شاء الله. والله الله
ان شاء الله
يعطيك
خير.
العافية.
الله ييسر. يوم
الله
الاربعاء
يسلمك.
رايح وبرجع يوم الاحد ان شاء الله خير.
بالسلامة
ان شاء
الله.
الله.
تسلم. الله يسلمك. تسلم. يعطيك العافيه.
We can start now.
Okay, I will share my
السلام
screen.
عليكم ورحمة الله. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. I would like to welcome to the Middle East Ophthalmology meeting, MEOM Academy, and to MEOM weekly meeting. And today we are going to have two parts as most of the time. So the first part, it will be expanding experience with Vabysmo. It will be the first part. I will moderate the first part. The second part, it will be moderated by Professor Dr. Mahmoud Al-Salem. He's a professor of ophthalmology, consultant ophthalmic surgeon, Al-Salem Eye Clinic, Jordan, Oculoplastic Surgeon. Our speaker today, Dr. Abdulaziz Badla. He's the president of Middle East Africa Council of Ophthalmology, MEOM, consultant ophthalmic VR surgeon, Sulaiman Al Habib Hospital in Dubai, and he will give the first part, expanding experience with the Vabysmo. In the second part, which will be about the lacrimal obstruction module, we will have an eminent speaker today. We are proud to have all these eminent speakers in this field. First, our guest speaker today, Professor Jane Oliver. She's a medical director and FRCO ophthalmic consultant, ophthalmologist, oculoplastic, and lacrimal surgeon, Clinical London in London. A leading pediatric and adult ophthalmology and dermatology medical clinic. Our other speakers, also Professor Muhammad Mu'in. He is an FRCS Edinburgh, FRCO ophthalmology, MRCO ophthalmic, MCSP. He's the president of Ophthalmic Society of Pakistan, Lahore branch, editor-in-chief, Pakistan Journal of Ophthalmology, chairman, scientific committee of Afro-Asian Academy of Ophthalmology meeting in 2022, director, medical education. Also, we'll have my friends, Dr. Tariq Muhammad Al-Duwais. He's an ophthalmic consultant, Arab and Jordanian Ophthalmic Board. He's Oculoplasty and Ocular Oncology Fellowship, LV Prasad Eye Institute, Hyderabad, India. He's a Pediatric and Strabismus Fellowship, Milan, Italy, Assistant Professor at UST University. Also, we are proud to have also today with us Dr. Thabit Mustafa Udat, and he is MD, FRCS, Glasgow. He's the president of Jordanian Ophthalmic Society, senior ophthalmic consultant, oculoplastic and orbital surgeon, Royal Medical Service of Jordan. Before we move to our sessions and to start with the first part, I want to announce that this is the last episode for the oculoplastic module. And the CME certificate, it will be issued after we finish the quick conference that will be held on 17 and 18 of June. So I would like to invite everybody to attend this one. It will be for 2 days, virtual, and we have many sessions, all subspecialties with a very eminent speakers worldwide. So without any further ado, we'd like to welcome Dr. Abdulaziz Badla with the first part. And before that, I would like also to thank Roche for sponsoring this meeting. Thank you. Dr. Abdulaziz, you can share the screen.
Yeah, I'm trying. Yeah, it's clear now, Dr. Muhammad?
No, you didn't share the screen yet. Like what you have done before, just open it. It should be open. And then just click share and select.
Yeah, I did. Now, okay.
Dr. Yes, please.
Yeah.
Okay, yes.
Bismillah ar-Rahman ar-Rahim. I would like to thank my dear friend, Dr. Muhammad Al-Amri and Roche, for inviting me to this nice webinar. And I will speak today about management of diabetic retinopathy, and especially clinical significant macular edema, diabetic clinical significant macular edema. And I will speak a little bit about age-related macular degeneration. We know that the incidence of blindness is 20 times greater in diabetes than non-diabetes, and diabetic retinopathy is a commonest cause of blindness between the age of 20 and 65 years, and this is the most productive period in the age of the people. And this is due mostly to the diabetic macular edema. Although diabetic itself cannot be prevented, in many cases, its blinding complication can be moderated. And unfortunately, many diabetics are not managed appropriately. Always, we're looking for chronic hyperglycemia in the pathology of diabetic retinopathy. And the pathology of diabetic retinopathy is microvascular complication, which could affect the outer part of the blood vessels and increase the leakage, and this will lead to the macular edema, or the endothelial part of the blood vessels, which is leads to the obstruction of these blood vessels, and after that ischemia and new vascular formation and the complication of this new vascular formation, which can lead to bleeding or to the fibrovascular membrane formation. That's why almost always we're looking for the hemoglobin A H1C. And nowadays there is a tendency to include the degree of hemoglobin A1C in the degree of the diabetic retinopathy itself. The risk factor for diabetic retinopathy: uncontrolled glycemia, high blood pressure, smoking, and dyslipidemia. And dyslipidemia is a very important factor in the accelerating of diabetic retinopathy. And sometimes we and our colleagues, the only treatment which we ask the patient to do is only to control his diabetes and his dyslipidemia, and this is the treatment only for the early stage of the diabetic macular edema. And there are a lot of papers and studies which emphasize the control of the dyslipidemia in the treatment of the diabetic retinopathy. For the diagnosis, we have color fundus photo, fluorescein angiography, and OCT. And nowadays we have also OCTA, which can tell us about the capillary dropout, and which also can tell us about the microaneurysm and the new vessel. In classification, diabetic retinopathy can be classified as non-proliferative and proliferative diabetic retinopathy, with or without macular edema. And almost always, the clinical significant macular edema should be treated, even in the proliferative retinopathy. If you have the patient with, let's say, with vitreous hemorrhage and diabetic macular edema, we have to treat the diabetic macular edema first and go for the laser or for the other option of the treatment. We have the first line of the treatment of diabetic macular edema is using anti-VEGF, and we have several kinds of anti-VEGF. We have Avastin, ranibizumab, aflibercept, and the last treatment is faricimab. And I will speak now about the faricimab and how he can use for the treatment, and I will explain what's the meaning of PTI, personalized treatment intervals, and this is the keyboard, the key point in this treatment. So we know that all the anti-VEGF, all the previous medication, it works as anti-VEGF, but faricimab has double or dual effect. It affects the anti-angioprotein, which is stabilize the vessels and prevents the leakage, and also faricimab is anti-VEGF, which reduces the vascular leakage and inhibits the neovascularization. So it has dual action. And Smith and Ryan Babismo study phase 3 emphasize that in the if we use the faricimab as a treatment for the diabetic macular edema, we can have a long intervals between the injection. So I will tell how we can treat with faricimab. So we inject 4 injections first until we get the macular thickness under the 325 micron, and after that we check the patient after 8 weeks and after 12 weeks and after 16 weeks. So every time we inject the patient, and if the patient is stabilized, we extend. So if we see the patient after 8 weeks from the 4 first injection and the macular edema was stabilized and the edema was dry, we extend the next interval to 3 months. And after 3 months, if the macular edema is stabilized, we extend until the 4 months. And that's why in this way, we personalize the treatment interval. And this is very important in the real treatment to the patient. And I will now show some examples how this patient, they can't be committed to the medical treatment, and they can sometimes they can't come on time. This patient, he came to me, he was complaining only from headache. Only this complaint was headache, and he didn't recognize any vision disturbance. And I was astonished that time. And when we checked his blood pressure, his blood pressure was over 20, and his vision was reduced, 20/60, about 20/60 each eye, and he has this macular edema. The macular thickness in the right eye is 745 micron, and in the left eye, 507 micron. And we decide to inject this patient with faricimab. And this photo before this OCT before the treatment, and this photo after the treatment. This is about 3 months after the treatment. This patient, he should come. I asked him to come after 1 month, but he didn't come. We called him, and he come about after 3 months, and fortunately, he has a good effect. As we see that the macular thickness become to normal from 1 injection of faricimab, and also in the left eye, and the vision improved to 20/28 in the right and 20/40 in the left. And we decided to continue the injection. this was after the second injection. Also, the vision in the right was improved, but in the left was still not improved. Still as same as the last visit. So the reason for not improving the vision in the left eye, even the macular thickness came to the normal, that there is a disturbance in the ISOS layer at the center of the fovea, and as it's shown in the second photo. And I continue injecting him, and he has the third injection now. I will speak a little bit about the macular age-related macular degeneration. And as we know, also we have a very informative study. It's done for this kind of patient, and also we have a long interval. So the aim of Vabysmo or faricimab to have the interval between the injection longer than the normal. That in the first year we can have we see that 45 of the patient has 4 months interval, and in the second year this percentage has been increased to about 65 of patients. So it is very nice to have this period more longer than the other anti-VEGF. And the way of injecting, also we always follow the treat and extend method in this in the treatment of the in the injection, and also with the other anti-VEGF. Always for me at least, I follow this one. And also we know that there is 3 types of injection. The first one is PRN, so we inject the patient and see him after that, and we can decide if we want to inject or not, or the monthly injection. And I don't think that nowadays anybody follows this way, and the treat and extend. And in the wet AMD, according to Tenaya and the Lucerin study, we inject 4 times with monthly injection and see the patient after 1 month. If the macula is dry, we see him after next month. If the macula is dry, after the 3rd month, and if the macula is dry, after the 4th month, and we inject at this time, and we keep this 4 months interval. Also, this patient, he has he came to me. He in the left eye, he has end stage of age-related macular degeneration, disc form scar, and this eye he has this OCT. As we see that he has this pigment epithelium detachment, and I decide to inject him because if we look to the first photo, we can see at the right of this PED, we can see a fluid, subretinal fluid, and also and the left at the left of this PED, we see the subretinal fluid, and I decided to inject him. So he came on 8th of October, and until we get the approval from the insurance, we inject him on 6th of November, so after about 1 month, and his vision was 20/28 -2. And after this injection, also he lost his follow-up. That's why always we emphasize that the long-acting anti-VEGF is help us, because in the real life, we expect everything from the patient. This patient, even he is high educated, I told him, why you didn't come to me? He said, I was on board, and and this is the right eye is only his eye, which can see with it. And he came after about 3 months, with hemorrhagic pigment epithelium detachment, and also we can see subretinal fluid, and his vision is dropped to 20/30, and also we inject him after 1 month until we have gotten the approval from the insurance, and his vision dropped to 20/30. After second injection, we can see that the macula started to be stabilized, but the vision went down for the 20/40 -1. And after the third injection, also the vision become 20/50. And here I have to stop sometimes to discuss the question that should we inject until we get the macula completely dry? And the answer always yes. Even sometimes the vision could be better when we have some subretinal fluid, but we have to inject until the macula become completely dry. Even here, the reason for the reduce of the vision is that there is an atrophic RPE, and even that we have to inject until we get the macula completely dry. The other pipeline for the treatment of the macular edema, we have gene therapy. We can inject intravitreal, and it has some complication like hypotony and intravitreal inflammation. And now we have also suprachoroidal injection of the gene therapy. Steroids we can use in preocular, intraocular, and laser treatment. And the best way now to treat the macular edema is with the micropulse laser treatment, because it doesn't have any burning effect on the retina. Sometimes we have to do surgery, like these cases, chronic macular edema, and macular and lamellar macular has developed, and the decision has taken to do vitrectomy for this patient with ILM peeling. After staining of the ILM by trypan blue, dissecting of ILM has been started. This surgery has been done about 13 years ago. And in that time, we don't have the method to treat the macular hole with inverting flap or with sparing inverting flap. That's why complete ILM peeling was accomplished using the 23 gauge in the gripping forceps. And as we can see that this patient was hypertensive and diabetic for a long time. And the optic disc, as we can see, it's slightly pale. I'm extending the ILM peeling until the arcade. Nowadays, all of these cases, I manage them by the inverted flap. Now fluid air exchange. I'm using 27 gauge, 23 gauge, in 23 gauge fluid needle, doing fluid air exchange to dry, and injecting of triamcinolone at the end of the surgery to reduce the macular edema. In conclusion, always we prefer to start with simple procedures, even if we ask the patient to control all the risk factors. We have to personalize our treatment. We have to know our patient. Some patients can't do the follow-up, and we have to consider this. And of course, the long interval anti-VEGF or medication is more advantageous. Thank you for your kind attention.
Thank you very much, Dr. Abdulaziz, for this excellent presentation as usual. So you take us a journey from the A to Z in management of diabetic macular edema. As we are talking mainly now about the latest treatment of management of diabetic macular edema, and you know that Vabysmo one of the latest. So what does it make difference, I mean, in your practice when you are using the Vabysmo in management
So
of
now what I find, I still don't have the chance to do the long follow-up, because I have started, you know, we have started the treatment of Vabysmo since last year, and I don't have the chance to do the follow-up for 2 years and to enjoy this a long interval. But what I have seen that Vabysmo, as we have seen in this case which I have presented now, that he has a very very rapid effect, and in this diabetic patient, we can get the dryness of the macula after first injection. And this is what we found in the USMIT study, that 45 of patients can get the dryness of the macular edema after 16 weeks of injection. And this is what I have found. But I am happy to have this anti-VEGF in my hand, that as we have seen now, that this patient he came after 3 months. If he only has his one eye to see this, because left eye, the vision was hand motion, and we can expect everything from our patient. That's why when we have this long-acting medication, we have to consider that we are happy to have this one.
But I mean, Dr. Abdulaziz, now when we are looking for any medications, for example, the optimal medications, we are looking durability. One of them, this is one of the most important that we are looking now in the management of diabetic macular edema. Efficacy also, and also if we can cure the disease, which is, I know it's far away from our discussions, but if we talk about the efficacy of the
I talked about the efficacy and also about the durability, because when I see this, because the study said like this, and in my hand also I can see it is durable, because the effect in the first patient which I have presented, and the second patient, we still get the effect even after 3 months of the injection.
Okay, when you are switching nowadays, are you still, I mean, are you going to switch or to use it as the first line of treatment?
So now,
I mean, you have a patient now, a diabetic or AM, you are going to start from the beginning, or you are going to do use another medication, then switch?
So, no, I start with Vabysmo, and also I start this treatment with the naive patient, and also I switch it from the other anti-VEGF when I find resistance from the other anti-VEGF, and this is all the study which have shown that if we have resistance from the one anti-VEGF, we shifted to other one, and I consider now Vabysmo as an option for this treatment.
There are two questions from the audience
in the chat.
Actually,
I will ask the last question from my side, then maybe I can take the other one fast. So if you have Dr. Abdulaziz switch from one medications previous anti-VEGF to Vabysmo, are you going to use it as a loading dose from the start, or you will continue, for example, when, and then you will follow up?
Yeah, I will. Usually, I shift after 3 injection of anti-VEGF. After 3 injection, if I can't see the effect, I switch to the other one, but I don't use the loading dose. I use the PRN method in this way. Yeah. So if I am sure that the patient will come after 1 month, I will see after 1 month, and I can follow up him. And in this I will use the longer interval, you know. So I saw him after 1 month, and I inject him for sure the second one, but I expand the interval.
There is one question from one of our colleagues, Yasser. He is during extending the follow-up, are we giving injection if the thickness
yes,
less
yes,
than
yeah. In the diabetes, yes, we inject. Yeah. So we give 4 injections, yes, please.
You say in diabetes. How about in wet AMD?
In wet AMD, we give 4 injection, monthly injection, and see the patient after 1 month. Sorry?
We are talking about the same question, that if it is less than 300, if you are going to still to give injection where? In diabetes or in both diabetes and wet AMD?
Yeah, I will repeat. In diabetes, we give 4 injection, okay, until we get the macular thickness under the 325 micron, okay. If we get this one, this effect, I will see the patient after 8 weeks, okay, and I will inject him. If he is stabilized, I will extend to 3 months to 12 weeks. And also the study says that I have to inject, but for me, I don't have patient for this all of this long period. But the USMS study said that we see the patient, we extend the interval for 8 weeks and inject. And if the patient is stabilized, we extend for 16 weeks and inject. And now we have the interval every 16 weeks. This is for the diabetes, okay? And for the wet age-related macular degeneration, we inject 4 injections until we get the macula dry, and we see the patient after 1 month. If he is good, we not inject. After 2 months, if the macula is still dry, we don't inject. After 3rd month, if the macula is dry, we don't inject, but we inject. We see him after 16 weeks and inject, even he is stabilized. And we keep this 4 months interval. And if we inject him if we find that we have to inject him after 8 weeks, we inject him after 8 weeks, and we keep this 8 weeks interval.
Thank you very much, Dr. Abdulaziz, for this excellent discussion. Now I forward the mic for Dr. Mahmoud.
Thank you, Dr. Abdulaziz. Thank you, Dr. Muhammad. Just I want to comment on very excellent and nice lecture of Dr. Abdulaziz, and also I take this opportunity of the 2 chairmen now present, Dr. Abdulaziz and Dr. Muhammad, and ask them that when we speak as subspecialty, we should reduce a little bit abbreviations as much as possible, so that people with other subspecialty can really get it. For example, when you speak about layers, SI layer, L.
Yes.
IL layer,
this is the photoreceptors layer. I know you know this one, but you asked me to explain to the audience.
Sure.
Yeah, ISR, it means that the junction between inner segment and outer segment of photoreceptors, which is the most important layer in the vision. When we have the defect in this layer, we can expect that the vision is still reduced, even the macula is getting dry. Okay.
Because I am one of the advocates. I am one of the advocates for the general ophthalmology. General ophthalmology is a branch by itself, and he should know almost everything. يعني خلينا let us say he should know يعني something about everything. Yes, we want to know about retina, about pediatric, about a cornea, but if we are so engaged with the abbreviations, we cannot learn. We cannot learn.
Okay, yeah, but Dr.
We are
Mohammed,
facing the
yeah,
same
the
problem with
audience is
oculoplasty
free to ask
technique.
us.
We are also
We
the
are ready
same.
anyway.
Yalla, okay. Thank you.
Yeah.
Anyway, thank you, Dr. Abdul
Very
Aziz.
much.
That was very beautiful.
Thank you again, Dr. Muhammad and Roche Company for inviting me for this nice meeting. You know, and also it is a chance to see my good friend.
Ahlin, thank you. Bye bye. Thank you. Fine. I will share my screen now.
For inviting me for this nice meeting. You know, and also it is a chance to see my good friend.
Ahlin, thank you. Thank you. Bye bye. Thank you. Fine. I will share my screen. Can you see my screen?
Yes,
Dr.
we can see
Muhammad?
your screen. Yes, yes, we
Fine,
can see,
fine.
Doctor. Go ahead.
First of all, I want to greet all my panelist speakers, and I am grateful that they agreed to come along and share me this session. I hope it will be fruitful and educative. Actually, the questions I have put, some of them are so straightforward, so basic, or so down to the ground. Some of them are controversial. Some of them, even I wonder whether they need two choices or not. This is why we need some discussion for it. Thank you, Dr. Jane. Thank you, Dr. Moeen. Thank you, Dr. Thabit Audat, and thank you, Dr. Duwais. Fine, and above all, thank Dr. Muhammad Al-Amri. He is the man behind all this thing. So we go on along now, and this is my first question. Are you ready, Shuria? My first question is that about an infant with congenital nasolacrimal duct obstruction undergoes lacrimal probing. Starting from the punctum, what distance will the probe travel before reaching the inferior meatus? Can we have the poll, please? Can we see the results? Fine. So really, it looks like a difficult question for the audience. I thought it was easy, straightforward. This is why we need to stop and say, Dr. Jane, what do you think? I mean, every who really embark on probing should have a mental image about the measurement of how much the probe will go in children or in adults. Yes, please.
It always surprises me in a child under the age of 1, or well, that age, how small it is and how short. So 12 millimeters would have been my guess. If it was nearer to 1 year old, you could argue 20, but I think not. I think it's nearer 12. And it's kind of a trick question because you're going from the punctum to the inferior meatus. You're not going to the floor. So if you go to the floor, that's another 4 or 5 millimeters below the opening in the inferior meatus, or it can be. So I think there's only one person who's going to get full marks on this multiple choice, and that is the author who knows the answer.
Yes, I mean, the author says it's a 20 millimeter.
Well,
what do you think?
Right. 20 could be right.
It would be her.
But 24, no.
But it's not 24, it's not, 30 and so forth. Then adults is 33, always say. Is that a golden number? An adult 33?
There to there.
Yes, maybe. Fine. Fine, okay, just we will proceed with another one. Now, question number 2. With regard to congenital nasolacrimal duct obstruction, A, 50% resolved in the first year of life. B, imperforate membrane at the level of Hassner is present in half of the newborns. C, long-term topical antibiotics have a role in the management. D, probing should be performed before age of 6 months. Can we have the poll, please? عارف هذا. يلا submit. It's another tricky one anyway. Fine. So Dr. Muayin with us, Muhammad Muayin, would like to comment on this results, and what do you think?
Yes, I think people are looking at what they have over here is 50% resolved. It's usually the 90% which resolved by the first year of life. And I think you're trying to highlight what the imperfect membrane and valve of Hassner's are present in half of the patients. And long-term antibiotics do not sort of actually make the thing resolve, and probing is usually reserved after 9 months or 1 year of age.
Mm-hmm. Fine. That's how the 50% resolution in the first year of life. What do you think? I know it is 90%.
90%, yeah.
Resolved. So this is a wrong actually. And okay, fine. Do you think antibiotics, topical antibiotic, have a role in the management?
They have a role in the management, but they don't actually resolve the problem. The antibiotics will just I would say if you use antibiotics for 1 or 2 weeks, that tends to reduce the discharge what you have, but the water keeps flowing, and then after 2 to 3 weeks, then they start again having the infection, because it's just like a blocked river that starts to collect all the bad material and starts to get infected.
Any of the speakers would like to comment on this again?
Yes, I would add something.
Yes.
Dr. Mahmoud.
Yes.
We can do probing before 6 months in special circumstance, like patient undergo cataract surgery for congenital cataract, or severe mucopurulent conjunctivitis, repeated many things. We can do probing before 6 months. Are you listening to me?
Sometimes, yes. I got you. There are certain indications for early probing,
Yes.
but actually, it's not meant in this question. Actually, is the most accurate thing is the imperforate membrane, is the valve
Yes,
of Hassner,
yes.
of course.
Yes,
I think
that's
the
right.
point
Yes.
about the
But if you have
imperfect
a congenital mucocele or whatever you want to, yes, Dr. Jen. Yes, Dr. Jen.
I think why sometimes people don't think about the imperfect membrane is that they forget that the baby doesn't cry for the first 3 weeks of life. So they're not really producing enough tears, and they're not going to get a watery eye. So most of those imperfect membranes are going to be gradually opening asymptomatically, and just a small number won't open.
Yes, okay. Thank you. Fine. So I think we'll proceed here. Fine. So a number of questions also about congenital nasolacrimal duct obstruction in children. Which one of the following is an indication for probing of the nasolacrimal system? In congenital nasolacrimal duct obstruction. A, acute episode of acquired dacryocystitis. B, intermittent acquired dacryocystitis. C, congenital nasolacrimal duct obstruction unresponsive to massage. D, workup of all patients with epiphora. Can we have the poll, please? Yes, the results. Okay, fine. So, well, it looks like straightforward, easy question. 74% right. So our audience were all on. Dr. Thabit Odat, would you like to comment? What do you think? Do we need to have a probing for every patient with epiphora?
Yeah, thank you very much, Dr. Mahmoud, for the invitation, and thank you for the nice photos. Actually, they are very good photos.
By the way, I have to congratulate you because you are become brigadier. What?
Thank you very much.
Now, I mean, he has promoted last week or whatever.
Yeah.
Okay.
Thank you.
Yes.
Thank you
Congratulations.
very much. Congratulations. Thank you, sir. So this is actually a tricky question because any answer these can be an indication for probing. But the most accurate one, as you said, is the congenital nasolacrimal duct obstruction, which is responsive to massage. I have a comment here because some people, some oculoplasty consultants, they do the probing in the clinic before the age of 6 months without doing anesthesia. And most of the people, they wait for myself. Actually, myself, I wait until the age of 1 year and do it under general anesthesia. So not every patient should have probing before the age of 1 year. So it's better to wait. But acute episode of acquired dacryocystitis can be an indication after, let's say, if the patients get improvement after a few weeks, you can do probing. Even after intermittent acquired dacryocystitis also can be an indication. But it's not a workup for all patients with epiphora because most of them, more than 90%, they will improve by the age of 1 year.
Thank you. Thank you.
Thank you.
Proceed. Question number 4. As for intubation of congenital nasolacrimal duct obstruction, all are true except now we finished massage, finished probing. Now we want to intubate congenital nasolacrimal duct obstruction. A, after at least 1 failed probing. B, as a primary procedure in older children. C, as presenting mucocele in 3 months old. D, bicanalicular intubation is mandatory. Can we have the poll, please? So it's also could be tricky, but this is why I mean it's tricky. So we need to contribute. Who would like to start to comment on that? What do you think? Dr. Jane, Dr. Oliver.
I'll go through them in turn. Yes, after at least 1 failed probing, there's a good argument to do intubation, particularly if you feel that there is a little bit of grating, there may be some stenosis along there. Primary procedure in older children, the same applies because it means you may get away without having to do a DCR. With a presenting mucocele in a 3-month-old, so that's in the much younger group, it's probably the mucocele actually expands the whole of the nasolacrimal duct, and you may have a little cyst beneath the inferior meatus, and a lot of people would put in tubes in that situation. I do endoscopic endonasal monitoring of those, and if I feel it's open enough and it is a lacrimal sac nasolacrimal duct mucocele, I don't put in tubes. As for D, I don't think you should be putting tubes in every time you do a probing. What do the other panelists think?
Bicanalicular, it is, he said,
Yeah.
bicanalicular. Do you use bicanalicular always or mono?
I see you've got a lovely picture of the Rittling there. I'm very happy with bicanalicular riddling. They're very easy to
Yes.
remove.
Yes.
I think I prefer that to the monocanalicular riddling.
Monoc. Okay, fine. Dr. Muayin?
Yes, I think I would like to do a bicanalicular intubation in these patients compared to a unicanalicular. And as a primary procedure in older children, yes, I do it if they're like 4 or 5 years of age. And with a presenting mucocele in a 3-month-old child, I'll be just probably doing a probing in that patient and not a stents for that patient.
Okay, good. Any one of the panelists would like to share anything?
Yes,
Okay.
intubation
Dr.
after at
Chris
least
Tariq?
yes, intubation at least 2 fail probing. I think that's right.
Yes.
But yes, bicanalicular intubation is mandatory for all patients. That's exit.
Okay, fine. I think this is the right thing. Okay, so we now I think there is no picture here, but question 5 say, which one of the following functional tests of lacrimal drainage allows identification of a failure of the lacrimal pump mechanism? A, Shermer test. B, primary dye test, Jones 1 test, and D, dye disappearance test, and D, secondary dye test, Jones type 2, or Jones 2. Can we have the poll, please? There is a picture here somewhere. Fine. So fine. Dr. Thabit Audat, what do you think? Do you do these tests?
Yes, Shermer test, if you suspect that the patient is having dry eye, you need to measure how much the amount of tears that the patient is producing. So Shermer test is not an indication, it doesn't show the failure of lacrimal pump mechanism. For primary dye test, when you put the dye and see if the dye is coming out of the nasolacrimal duct through the nose, whether you put a cotton pad or you just wait the patient to sneeze to blow his nose and see if the dye is coming out or not. So it can show you if there's anatomical obstruction or something wrong, like dacrylate or anything else. Dye disappearance test, it can be, but it's not good for the physiological. It just shows you if there's anatomical obstruction, such as punctal stenosis or nasolacrimal duct obstruction. While secondary dye test, which is the Jones 2 test, when you irrigate after doing primary dye test 1. So this can show you if there's lacrimal pump mechanism or not. I think the answer is D.
Yes, good. Thank you. Anyone would like to comment on these tests? Do you do them kind of regularly and or when it's indicated? Dr. Muayin or Dr. Tariq? Dr.
Yes,
Tariq?
indicated, especially in patient previous history of facial nerve palsy and complaint of epiphora. We can do this routinely for this patient, but not routine for all patients.
Okay, thank you. Fine. Should I proceed? Okay, so that now, okay, the most physiological test for assessment of lacrimal drainage system will be B, syringing, B, dacryocystography, C, lacrimal scintigraphy or scintillography, D, Jones 2. Can we have the poll, please? Fine. Well, it looks like a difficult question. It seems no, we have to have some discussion around. Fine. Dr. Muayin? would
Yes,
you
I think
like
I
to
thought
comment?
it was a pretty simple question because you're checking the physiological test means that you're not forcing any fluid into the lacrimal passage in this case. So if you're doing syringing, you're using force, and acrocystography, you're still using a syringe to inject, while in lacrimal scintigraphy, you're doing nothing. You're just putting in a radioactive material in the lacrimal lake, and that goes through the lacrimal sac into the system. And Jones too, you're still injecting. So I think lacrimal scintigraphy is the most physiological test.
How frequent you ask about scintigraphy?
Very rarely, very
Very
rarely.
very rare, yes. Okay, but just to make the patient happy, I mean, to show that he has got obstruction somewhere underway. What do you think, Dr. Jane, Dr. Oliver?
I agree with Dr. Moyne. The A, B, and D all involve syringing, therefore it's not physiological per se. C, lacrimal scintigraphy is physiological, but actually I don't do it very often. As you say, it's only to show the patient. More often, if I want to know, I do a functional fluorescein dye retention test, which can often show you if they have unilateral watering, that it's more retained on one side than the other. And for me, that's a reasonable physiological test.
Okay, good. Fine. Anyone have more experience or different experience than this in lacrimal scintigraphy?
Lacrimal scintigraphy, actually, it can be done in pediatric age group also. So it's usually not needed. As you said, it's just to show the patients that he's having something wrong with the physiology of lacrimal drainage system. But it can be done it should be done in awake patients. It can be done even in pediatric age group. It shouldn't be done under general anesthesia because you need the blinking. You need the patients to be in the upright position, not in the supine. And he should be also awake for blinking to see the mechanism, if it's working or not. So it can be done at the age group also.
Fine. Okay, thank you. Okay, fine. Now, okay, we have seven. Seven. Question number 7. Say regarding dacrocystorhinostomy, so DCR, which is incorrect. A has a success rate of 90%. B requires a skin incision below the medial canthal tendon. C may require incision of the anterior limb of the medial canthal tendon. D usually requires silicone tube placement. Can we have the poll, please? Who put this question is very courageous man. So I would like to hear the comment of every one of you. I mean, like, do you put a tube always in DCR, or you are so satisfied that you did the, let us say, the anastomosis and you lift it and you do syringing afterwards. So طارق دويس دكتور طارق خلينا قول لي شو what do you do?
Yes. In my work I do silicone tube for all patients, but sometimes when I do good anastomosis, I put mitomycin C, and that gives good result like intubation. And there is some nasolacrimal duct obstruction like traumatic or rado DCR, you must do intubation.
Let's do it. Dr. Thabit.
Yes. This question actually, or this procedure, it has a very high success rate. It's more than 90%, up to 96%, even more. And we usually do put the silicone tube because it's available in our institution. But if you do the good posterior flap, if you suture the posterior flaps and the anterior flaps, usually it's not needed. If you have good osteotomy size, and you submerge the posterior and anterior flaps together, so it's not needed. Actually, it's not needed. But in our institution, yes, we do intubation for all patients.
Dr. Jane?
I used to use silicone tubes for all patients for both external DCR and endoscopic endonasal. And then I became a little braver, and now I will only put tubes in the following circumstances. If I've probed on the table and I feel that there is a canalicular stenosis that may be helped by the tubes being there, that's one. If I haven't felt that I've seen the common canalicular opening really well, surrounded by 2 or 3 millimeters of healthy-ish lacrimal mucosa, I would put the tubes in. If there was any doubt about the nose being narrow and maybe some turbinate in front that hasn't been cleared, then I might put the tubes in. But certainly for the last few months, I've not been putting tubes in, and the patients are loving it not having tubes. They don't feel them at the medial canthus. I don't think they're a big problem when they are there, but they're relieved they don't have tubes, and they don't have to have the, again, unjustified worry about having them removed. Also, sometimes, certainly in the endoscopic endonasal DCR, tubes can cause little granulomas to form there. So it would be a reason, that's one of the reasons I'm now not putting in tubes unless there's a positive indication.
Dr. Muayin?
Yes, I think if I'm doing a DCR and I've got good anterior and posterior lacrimal flaps, especially an external one, I would go not to put a tube in, but usually I would just do anterior flaps, and I tend to not be as brave as Dr. Jane, so I'd put DCR tubes. And if I'm doing an endonasal DCR, yes, I'll put in tubes for those patients.
Fine. Actually, have anybody looked to whether really putting a tube, it produces more success on the DCR results or no? I mean, is there any study that
Yes,
shows DCR without and DCR with the tube? Is there
yes,
any?
they are present on the internet, yeah.
Yes, fine.
There was one study by the Peter Dolman group in Canada of endonasal, transnasal DCR, where they found the tubes gave, I think, a 10% benefit. But one of the problems about that operation is that it's done with loops under direct view, and it may be that there is more risk for flaps and other fragments closing up the opening if you don't have the tubes.
I know how Peter Dolman does the DCR through with the magnification and fine. So I want to proceed. Fine. So question 8 now, also about the DCR. It's called the osteotomy site, fashioned at the time of dacrocystorhinostomy. A is adjacent to the valve of Hassner. B enlarges the opening of the common duct. C is adjacent to the superior turbinate. D is within 10 millimeter of racribriform plate. This is not my question. This I did connect it. I quoted from somewhere else. This is why I found it rather difficult or abnormal. I don't know what the author meant, but I want to hear from you. This is one of the board questions, actually. This is how people fail. Can we have the poll, please? Yes. The results, okay. Mhm. So I told you it's a difficult question. Now, the author meant it is within 10 millimeter of a cribriform plate. This is the question. This is the answer of this question. So what do you think? What's the significance of this question? Dr. Oliver, what do you think? Is it?
I think this is one of the best questions of the whole multiple choice, because it's reminding us that when we do a DCR, we are not very far away from the brain. And particularly if you've got some rongeurs and you are doing a twisting movement, you can do a fracture up into the brain with a CSF leak and they get a horrible headache. The other thing I just want to mention is A is adjacent to the valve of Hasner. It's always very difficult to remember which is the valve of Rosenmuller and which is the valve of Hasner. And for those of you who know Jeff Rose, who is very tall, I remember it from him. So Rose, the valve of Rosenmuller, is the one at the top on the entry into the sac, and the valve of Hasner is the one at the bottom. So that's how I remember which is which. So I'd like to tell you that.
Thank you. Thank you. So it's a very important questions. Dr. Ma'in, what do you think?
Yes, I think as Jane has very nicely pointed out, I think this makes you realize how close you are to the cribriform plate. And obviously it is not just adjacent to the superior turbinate, because your opening is actually at the anterior border of the middle turbinate. And it does not enlarge the opening of the common duct, because you're working on the bone and not on the canaliculus as such while doing an osteotomy.
Great. Thank you. Thank you. Anyone would like to comment more?
Yeah, and I think this is a very good question, because as Dr. Jane Wolver said, because it points to the how close we are to cribriform plates that would lead to a leak of CSF. So it's very important during the DCR, when you do bone cutting, not to twist your hands or to try to pull the bone. Just cut the bone while you are inside. Don't move your hand right, left, or up or down, because this might lead to CSF leak, because it's very close to the cribriform plates.
Fine. So, okay. Fine. We are right. Okay, yes. So now is a question number 9. Which one of the following suggests diagnosis of canaliculitis? A is a mucopurulent reflux from punctum with compression of the lacrimal sac. B is a gritty sensation on probing with yellow tinged concretions. A palpable subcutaneous mass above the medial canthal tendon. And D is a palpable masses in the lacrimal sac. Can we have the poll, please? So should be, yes, it's a rather straightforward, easy question. We are one of the moderate questions. So I think it is the Dr. Tariq Al-Duwais.
Yes. Which of the following suggests canaliculitis? It's straightforward. Gritty sensation on probing with yellow tin concretions. That's the right answer. Mucopurulent reflux from punctum when compression of lacrimal sac. That's diagnosis of nasolacrimal duct obstructions. Palpable subcutaneous mass above medial canthal tendon. That's wrong, because it's on canaliculi, not above the medial canthal tendon, and there is palpable masses in the lacrimal sac. That's also wrong. The right answer, gritty sensation on probing.
Great.
With yellow tin.
Actinomyces Israeli most of the time. And okay, fine. So yes. The same. So now the same theme. we are still in canaliculitis. So which of the following is the treatment of canaliculitis? A, probing, B, syringing, C, dilatation, D, canalectomy or canalectomy. Okay, can we have the poll, please? It was kind of a canalicular abscess, actually. Okay, so 63% almost got it right, so it was straightforward. But I want to know from Dr. Jane, Dr. Ma'in, and our other panelists how they do or handle, they open the canal for canaliculitis. Please, Dr. Ma'in, okay?
Yes, I think it's a very, very valid question, and it's a very tricky situation. If you don't know, it's easy to answer on the MCQ, but when you actually see it, but this, the picture you are showing here is pretty obvious, but usually it's very, the swelling is very little, and the patient just comes in with discharge coming out from that area. And usually when you treat these patients, they are very happy. And I would just do a 3-snip procedure and then use a curette to sort of take out all the concretions and all the material which is there, and then flush the canalicus with sort of antibiotics.
So you cut the vertical and the horizontal canaliculus.
Yes.
Okay,
Yes.
that's the truth. So Dr. Jane, what do you do?
I would dilate, if it needed it, dilate up the punctum. I would put in a Bowman probe or the end of a nettleship, and then I would do a cut down onto it. It's not exactly a 3-snip, it is actually a single cut. I don't go too far along. I go far enough along that I feel I can get everything out. In the upper one, it doesn't matter too much, but there's a risk in the lower canaliculus that if you make a slit or canaliculotomy too long, that they may actually have a epiphora afterwards because you're affecting the tear drainage that way.
Okay, fine. Fine. The pictures are my patients, my collection over the years.
Nice photo.
Fine, fine. Thank you, thank you.
What did you do?
Pardon?
What do you do?
Well, I do kind of a 3-snip operation, or just canalectomy. I open the canal. Even after dilatation, I put scissor with a very thin and long blade. I just cut with the scissor, and that's it. I try to get all the pus out or the concretion out. Depends, but some of these, for example, this patient, I think he needed all the lid margin to cut came out, and I had to cauterize a little bit here, because here I think it was kind of canalicular abscess to start with. But very fruitful. I mean, very good result usually once you do surgery for these patients.
Yeah.
Okay.
Can I add something?
Yes, please, Doctor.
Yes. I used to do punctal dilatation and take out the concretions by curette, small curette. But because of the dilatation of the canaliculus, there will be stagnation again, and there will be recurrence. After the procedure, I do syringing usually. But nowadays, I just do canaliculotomy. It gives very good results. I am not afraid of the slitting that will happen, because with the experience, you see the patients with DCR tube, they will have cheese wiring or slitting of the canaliculus, and they will not have any problem with the lacrimation or the epiphora. So it's very good to do canaliculotomy in all of the patients.
Very good, very good. But okay, this is a digression. I want to ask, how do you do? By what you do syringing? How do you? I mean, when you do syringing, do you use distilled water, saline, or anything else?
Normal
Because
saline.
not only because I
Yes.
am using antibiotics drops. I mean, like Tobrix or Oflox. What is handy in my clinic? I take it out and put it. What do you think? This is against I mean, uh, medical practice with. I mean, if we put the drops inside our eyes, why not to put it inside the lacrimal apparatus? What do you think, Dr. Jane?
I don't actually use any antibiotic or steroid with syringing with these because you're evacuating all of those little yellow sulfur granules. And once you've really opened that dilatation, which is halfway or so along the canaliculus, it's probably not highly likely not to come back. I do have them on some steroid antibiotic drops afterwards, but no need in my hands, or so far touch wood, to have to irrigate with antibiotic.
Dr. Muayin?
Yes, I do irrigate with antibiotics, but I think the only reason not to is probably if you haven't sort of curated the area enough and there's a sort of a chance that you might push the particles down the nasolacrimal system. That is probably one reason how you wouldn't. But what I tend to do is when I open the canaliculus, I would do a thorough curette so that, because there are many outpocketing out from the canalicula, which you have to sort of dig out, because it looks like it might be just one stone that's coming out, but there's so many of them that keep coming out.
Yes, yes.
I
Okay,
do.
Dr. Tariq, yes.
Yes, I do irrigation with antibiotics combined with the steroid only after probing. That's routine for me, all cases. Probing.
After probing? After
Probing.
probing? Probing, after
Yes.
probing. Okay.
It's
Fine.
routine for
I
me.
thought decongestant sometimes might also be helpful. Some decongestant drops or whatever. Might. Dr. Thabit Audat, yes.
Is your question, you mean syringing after canaculotomy or in general?
Yes, not in general, of course. Once if you canaliculitis or you feel.
I do actually. I do. I use whatever I have in the clinic. I do syringing with antibiotic eye drops.
Okay, thank you. Thank you.
Are you insert silicone stent or not for after?
No, especially if it is the disease in the upper, this is what I do. If the disease in the upper canaliculus, I try not to do any intubation. Okay, because or I don't like to use pigtail or whatever, so you can damage the lower punctum as well. You might damage, but no, I don't do that. Just slit it and keep it as it is. Okay, what do you do, Dr. Jane? Do you put any intubation?
No, I don't put any intubation.
Yes.
I would like to add that sometimes after this, they do get a blockage of their distal part of their upper or lower canaliculus, but they don't seem to be symptomatically troubled by it at all.
Thank you. So I think we will proceed. Fine. No, this is okay. This is one of my cases that I saw. I thought it was a tricky one. And he was 60-year-old with painful proptosis, fever not resolved for 3 days, and not responding to usual intensive antibiotics. Interrogation showed that the patient has recurrent epiphora and occasional dacrocystitis. Examination showed tense lower eyelid swelling, neuroimaging shown here. The diagnosis is A, acute dacrocystitis on top of chronic. B, orbital cellulitis. C, periorbital cellulitis. And D, not related to lacrimal sac. Can we have the poll, please? This is actually one of my patients that I saw, and yes, he presented with orbital cellulitis. and only the neuroimaging showed the source of this. And what I had to do is the DCR with the tube. And have you come across cases with acute dacryocystitis or dacryocystitis that produce orbital cellulitis? He had true orbital cellulitis, proptosis, limitation of ocular motility, and a full bone picture of orbital cellulitis. Dr. Jane.
Yes, I have come across this. You have to get them to theatre quite quickly because the curing thing is to drain the abscess.
Yes.
And do a DCR. Of course, you have an option of draining externally, but to go to primary DCR, whether endoscopic or external, is the best way. And of course, systemic antibiotics as well.
Dr. Mayin.
Yes, orbital cellulitis becomes an emergency. Probably start them on IV intravenous antibiotic and just get that sort of swelling less intense. And then I would go in for either, probably depends on how it responds to IV antibiotic. If it sort of resolves or it's quickly responding to it, probably I can wait. But if it's obviously not, then you can go in for drainage of the abscess.
Dr. Thabit.
Yes, we have to take into consideration that the lacrimal sac is pre-septal, and the pre-septal area is not post-septal. So although it is pre-septal, but it's very close to the orbit, so it can lead to orbital cellulitis. But just for educational purposes for the residents, it's a pre-septal structure. It's not post-septal. But I have come across these cases, and it's a top emergency that you have to admit and give IV antibiotic and do either drainage or do the DCR.
Well, periorbital cellulitis is the commonest complication after dacryocystitis, but we do cross orbital cellulitis cases.
Yeah.
Okay, Dr. Tariq, okay for you?
Okay, yes,
okay, thank you. We just go in. Fine. This is it says, question 12. What is the most common reason for failure of a DCR? A, obstruction at the level of common canaliculus or bony osteotomy site. B, unsuspected lacrimal sac tumor. C, recurrent infection of the lacrimal sac. D, dacryolyth lacrimal stone. This is one of the rare cases that I did neuroimaging for her, and it shows that she had got a sac. Okay, fine. So our next Okay, fine. So looks like a straightforward or rather clear question. That's obstruction at the level of common canaliculus or bony sites. So every one of you, Dr. Tariq Duwais,
yes.
What do you think?
Yes, the most common reason for failure of DCR is inadequate remove of bone or bony osteotomy. That's obstruction at the level of the common canaliculus or bony osteotomy site. That's the most common causes of failure of DCR.
Dr. Thabit.
Yes, actually, none of them can be a cause, but you ask about the most common reason for failure of DCR. So one of the reasons for good success or high percentage of success is the size of the osteotomy. The bigger the size of the osteotomy, the more the success rate will be. And the second one is the flaps. If you do a good flaps, anterior and posterior flaps, that will increase also the success rate. Sometimes there will be obstructions or fibrosis at the end of the common canaliculus. So if you ignore this part, this can lead also to obstruction of the failure of the DCR. So the answer is A.
Thank you. Dr. Mayin.
Yes, I think obstruction at the level of the common canaliculus or bony osteum, I think we must need to remember the sump syndrome in which you make a bony osteotomy, but that does not go low enough that there is sort of collection of material in the lower part. And those are the patients who would present with sort of regurgitation positive after doing a DCR. So it's very important to go down up to the level of the inferior orbit when you're making that osteotomy. And that is the level where you would probably get that. But if it's an unsuspected lacrimal tumor, probably if you've missed a tumor on the first go when you're doing surgery, probably that will be the only reason if you have a sac tumor. I think we did a fellowship in Cincinnati, and they were used to do lacrimal sac biopsy in all patients just to see if we sort of missed out anything. And I think 1 or 2 patients out of 500, there was one thing that came out suspicious.
Jane, Dr. Jane.
I think you have to ask yourself, why are you making a large osteotomy? You're making a large osteotomy so that you can open all of the sac and see all the way into it from the top to the bottom. So you want to be up at the apex, but you want to be low enough that you're at the nasolacrimal duct sac junction, and you must see the common canalicular opening. And if I talk about having 4 or 5 millimeters around of healthy.
Short. I missed your voice. I missed your voice. Okay, hello.
Hello, am I back?
Hello. Yes,
Hello.
you are
I'm
okay.
not sure how much you heard. I just stressed the importance of the osteotomy size being large, not for the sake of it, but for a very real reason. And that's you want to open all of the sac and see the common canalicular opening. And then I was asking, may I be permitted to comment on this top photo, please?
Yes, please comment.
Oh, well, I don't know exactly what's here, but I just think there's a mass here displacing the lid and the eye upwards and a bit outwards. And then in the lower one, there is, it could just be a large mucocele, but I'd love to know what it actually was.
It is a mucocele.
Really?
It's a mucocele.
Lovely.
This is a mucocele, and this is the same patient with a mucocele. That's a mucocele, chronic mucocele. Yes.
In a
Chronic
situation
mucocele.
like that, if people see that where the medial canthus is higher on one side, then they have to be extra suspicious that there may be an unsuspected lacrimal sac tumor.
Well, yes. Well, about the osteotomy site, it's not only the size. The size is very important. You want to do adequate size, but the site of the
location is very important.
The location very important.
You said, yes.
And also in my practice, I found we have somehow an anterior ethmoid sinus sometimes comes in the way, and some of the surgeons do DCR. They are in the ethmoid, and they haven't really went into the nose, and they think that they have already did the DCR. They didn't do it, and some anterior ethmoids sometimes are misplaced anteriorly, and they are in a cavity, but this cavity is in anterior ethmoids. It's not the nasal mucosa. They did anastomosis with. I have seen these cases.
Yeah, so some of the patients, they have giant air cells, actually, as you said, and this might be the cause of the obstruction. It's pushing the sac laterally, and sometimes some of the surgeons, they just open the anterior wall and forget the posterior wall. That's why when you use the Q-tip in the nose, you can feel that you cannot feel the mucosa. That's the idea behind the using the Q-tips, because you can do a vasoconstriction and see if you are inside the nose or not. You can feel the mucosa.
Thank you. I think we proceed. Dr. Jane, do you have any comment on this?
No, I agree with you on all of that. Yes.
Thank you. Thank you. Great. Thank you. Fine. Say all of the following are indications for conjunctivodacrocystorhinostomy or CDCR, Jones tube procedure, except lacrimal canaliculi have been destroyed. B, canalicular remnants cannot be anastomosed with the intranasal cavity. Common canalicular obstruction combined with nasolacrimal duct obstruction. D, paralytic or scarred eyelid with absent canalicular bump mechanism. Okay, can we have the poll, please? So the question about the Jones tube intubation, when you do it, and I think almost 50% of the audience got it right. It's we don't do it for common canalicular obstruction combined with nasolacrimal duct. I mean, we do something else. So, Dr. Dr. Thabit,
Yes.
what do you do?
As you said, lacrimal caniculi have been destroyed, so you cannot do DCR in this case. You cannot do intubation. So you should do put Jones tube or to create a new passage for the tears to go through the nose. Canalicular remnant, sometimes if you have destroyed the canalicular system and you have just remnant parts, you cannot anastomose with the intranasal cavity mucosa. So this is also an indications. If the patient's having absent canalicular bumping mechanism, again, you cannot do DCR because it's already opened. So you have to put Jones tube. So the correct answer is the common canalicular obstruction combined with the nasolacrimal duct obstruction.
Yes, yes, very good. Anyone would like to comment on this? Okay, so we proceed. Fine. So question 14 says the tube shown in this figure is monocanalicular tube, minimonoca tube, Mitera tube, lacrimal terrifying. So can we have the poll, please? Fine, okay. It seems the audience got it, and it is clear. How frequent do you use the minimonoca tube, Dr. Jane, and when do you use it?
I don't use a mini Monica a lot. I would use it with an inferior canalicular laceration, but I prefer bicanalicular because I think that helps bring the upper and lower punctum in towards the medial canthus, and then you don't have to do so much to repair the posterior limb of the medial canthal tendon. And you theoretically, they're going to drain the tears around the silicone tube. But I've seen some very good results with the mini Monica, where people have got staphylococcal lid margin disease and canalicular stenosis. And we've been able to leave a mini Monica in for maybe 3 months and with a good result functionally and syringing afterwards.
The bicanalicular you use is Rittling.
I like the Rittling very much because I've had a lot of experience with the Rittling with children, but the Crawford is fine as well.
Fine, fine. But minimonoca is easier to remove. When you want to remove it, you don't have to.
The others aren't that difficult to remove.
You need the GA for it, isn't it? Bicanalicular.
The Rittling is very fine, and you can, depending on how you've done your knots, you can often bring it back through the medial canthus. It's in a child. I'm thinking of a child maybe around about 7, so semi-cooperative.
Dr. Thabit?
Yeah, Actually, this questions, a monocanacular tube and mini monoca, they are the same. Because monoca, it means mono, which is one, and canaliculus. So both of them can be correct answer. But it is, for this picture, it's mini monoca tube. Usually use it just for canicular laceration. For punctal stenosis in patients with staphylococcus, we usually use self-retaining tubes, which is auto-stable tube. Nowadays is available from FCI. So it's much easier to insert, and the patient usually, they are happy with the auto-stable tubes.
Great, great. Anyone would like to comment
Yes.
or add? Yes, Dr. Tariq.
Yes, that's mini monoca because of stump or that's.
Mm.
I do mini monoca for all patients for lower or upper canicular laceration, and this give a good result. I cannot use the pigtail at all. I think that's mini
It's a
monoca
difficult. It was
safe
a difficult.
and
Yes,
good
of course.
result.
With it. Thank you.
I think mini monoca is useful if you are not very used to using a bicanalicular stent, and suppose you have a lacrimal laceration and you're not a very sort of an oculoplastic surgeon, probably that you can use at that time because it's easier to use compared to, because the bicanalicular stent is not going to be easily placed in until you know where it's going.
Great, great. Fine. Fine. Okay. It's about the punctal stenosis. Punctal stenosis is treated by all except perforated punctal plug, three snip operation, C, punctal dilatation, D, lacrimal intubation. Okay, can we have the poll, please? Can be a tricky question. Oh, yes, I told you, can be a So what do you think, Dr. Muayin?
I think lacrimal intubation is not used for punctal stenosis. It's mostly used if you're suspecting that you might get canalicular stenosis, especially in patients who are going 5FU therapy or similar thing like that. While punctum dilation is required for sort of punctal stenosis is treated with punctal dilation, and 3-SIP procedure is a known treatment for that. I think perforated punctal plugs is one of the best treatments, which is now at times available, and which produces the least sort of trauma to the canaliculus.
Perforated punctal plugs are used for young individuals. 3-snip operation are used for the old. What do you think? Is it logic?
I am very skeptical about. I know 3-snip is a good procedure, but I'm very skeptical about opening up the canaliculus at that time, because if you're doing 3-snip once, probably it's very difficult if you have to deal with DCR later on and those type of stuff. So I would think about using perforated punctal plugs.
Did you ever experience perforated punctal plug might migrate or whatever? Sometimes either they are expelled out.
Yeah, mostly they are expelled out. Yeah, because I use punctal plugs as such, and they usually last for a year or something, and then they come out by themselves. Yes, that is an issue with them. But the main thing is, while they're in there, they're causing punctum dilation as well.
So what about lacrimal intubation? Is it logic?
Lacrimal intubation, probably it's an overdue for a thing which you can do without actually going inside. Probably if you're not experienced, or you can actually damage the lacrimal system while doing an intubation.
Dr. Jane?
I've used perforated punctal plugs, and I agree with Dr. Moyne that it's a way of doing a punctal dilation for a longer period of time. Whether the tears really are going through that little hole in the middle, I'm not entirely sure. punctal dilation can work in some as a standalone thing. For a 3-snip, I hate the 3-snip, and I will occasionally do what I call a very mini 3-snip. It's more like a 2-snip, because I don't want to damage the canaliculus. I want it to be effective, but minimally invasive.
Fine. Who would like anyone like to add something?
Yeah.
Yes.
I
Yes,
usually
Doctor.
prefer not to go to the destructive procedure like 3-snip operation until the end. If everything failed, then I will go to the 3-snip operation. I usually start with peripheral spinal plugs, but the problem with them, they are large and it's difficult to insert them easily. So you have to be sometimes aggressive with dilatation to insert them. The second thing, punctal dilatation, usually the patients will come back within a few weeks complaining again of epidural. And if you want to be aggressive, this will cause damage to the punctum, and this might lead to fibrosis. Lacrimal intubation nowadays, as I said, I usually use the self-retaining tubes and gives very good results. Self-retaining, you can do it as the sit lamp, or you can do it in the theater. It's a painless procedure. Sometimes you have to give local anesthesia if the patient is not tolerating the pain or the discomfort, but it's easy to insert because it has guide wires with it, and it gives very good results. The problem is it's not cheap. It costs about 130 JDs.
This is the idea. Yes,
All
this is the idea. Okay.
Yeah.
Yes,
Yes,
thank you. Yes, Dr. Tariq.
Like Dr. Thabit, start with simple procedures, punctal dilatations, perforated punctal plugs placed for 2 to 3 months. It gives a good result. If fail, 3-snip test, vertical and horizontal, that's the end result or end management of punctal stenosis.
Thank you. Thank you. Now, so this question, so number 16, say obstruction at the site 2, and it's a far end of the lacrimal canaliculus here, would require lacrimal terrifying, mini-Minoka, intubation, DCR. Can we have the poll, please? Obstruction at 2. It's obstruction at the far end of the lacrimal canaliculus, or did they say the distal end? You call it. So what do you do, Dr. Jane Oliver?
I think that looking at 2, it's marked as being a very small obstruction. If it truly is like that, you may be able to get through. The problem is that that obstruction may lead all the way to the common canaliculus, in which case you would need a lacrimal trephine.
Yes, true. Fine. This is what Dr. Muin.
Yes, I agree that lacrimal trephine is something which is needed, and that is a very useful thing which easily bypasses that area.
Fine. Okay. Anyone would like to add anything?
But do you need to insert a tube, mini-Minoka tube, after definition or not?
Yes, you have.
Intubation. A tube.
Otherwise, it will close again because of the fibrosis.
Yes, of course. Intubation. Fine. So my last question, so that I don't keep you for long. Okay. It is number 17. It's acute lancinating pain in the medial canthus region with minimal non-inflamed enlargement of the lacrimal sac is most suggestive of A, impacted dacryolet, B, acute dacryocystitis, C, chronic dacryocystitis, D, vaginal granulomatosis. So who would like to contribute? Anyone?
Pause it first.
It says acute lancinating pain. Can we have the poll, please? Okay. It seems has been answered. 55% say acute dacrylith, impacted dacrylith. So, so anyone would like to contribute? How frequent do you see it? I mean, like impacted dacrylith or
Very rare.
some stone. It's very rare, yes. We
Very
want
rare.
to, this is why we brought the experts. We want Dr. Main, what do you think?
I think it's very rarely it's seen, but I think the giveaway in the question is that there's no enlargement or inflammation of the lacrimal sac, which you would typically see in patients with dacrocystitis. So that is the only answer that comes, because in Wagner's granulomatosis, there'll always be inflammation as well. So that will only come as a dacrylith.
Dr. Jane, how frequent do you see
Very
dacryliths?
rarely.
Very
Vagus granulomatosis would most often be a chronic dacrocystitis. Acute, well, it isn't from the description. Impacted dacrylith is very rare. I do see sometimes dacryliths in what I call relatively young adults, so they may be 30 or 40, who have an acute onset of epiphora. There may be some discomfort with it, and after a few weeks, it goes away. And I always say to them, I think you've passed your stone. So similar to a renal stone, that when it's sort of gravel in the bottom of the sac, but seeing impacted dacryliths in the sac is rare. It's delightful when you open the sac and find them though.
Yes, I have seen it twice. I mean, it was at time of DCR, doing DCR, you open the sac and so forth, and you find something, stones or whatever, but I haven't ever diagnosed it preoperatively. So anybody could really diagnose it preoperatively?
I think for that, you would probably need to do a CT scan on all the patients for DCR, or at least an X-ray.
Yes, I think when we do a CT scan for all patients, we go into DCR, we can find many things like dacrylith. I think that.
Just to add, I find dacryliths are more common in the nasolacrimal duct than in the sac.
Yes, in the nasolacrimal duct. Okay, yes, possible. Yes, fine. Fine, thank you. There is one question from the audience. Says about some researcher recorded that some of the children with nasolacrimal duct complained or have anisometropia. Anybody can comment on this? Nasolacrimal duct obstruction and anisometropia. I mean, not ptosis, there is anisometropia or whatever. Or does it really have anybody documented the congenital nasolacrimal duct obstruction and the anisometropia, or affect the refractive error of the patient?
Yeah, it's been reported by Abbas Bagheri, refractive state in children with unilateral. Yeah, unilateral. NLD
Yes.
is associated with anisometropia, especially, and isohyperopia, which also may predispose the children to amblyopia. This is a 2012 study.
Dr. Jane?
Just to say, fascinating. I'm sure it's possible, but I wasn't aware of it.
I think because of the high tier, because of the high tier meniscus, I think this will cause refractive error. It will change the refractive index of the cornea, and this can lead to refractive error in the patients. That can explain why the patients might have anisometropia or refractive error.
Okay. Well, anybody would like to add anything, Dr. Tariq?
Yes. So many patients.
Yes.
Yes, I saw many patients with the congenital nasolacrimal duct obstruction unilateral, and they have astigmatism. Why? I don't know. What's the relation between them?
Because they're always rubbing their eye like keratoconus. That could be the reason they might have astigmatism.
Possibly. Well, at the end, I would like to thank you. Thank every one of you. I have benefited myself. I learned also, and I enjoyed it. It was very fruitful, really, seminar. Thank you, Dr. Muayin. This is the first time with you in a session. And thank you, Jane. Thank you for really accepting. I know you have a lot of agenda, a lot of schedule in London and in Spain, everywhere. And looking forward to see you, inshallah, in Muscat.
Thank you. I've really enjoyed it.
Last month, inshallah. Thank you, Dr. Dewis. Thank you, Dr. Tariq. Thank you, Dr. Thabit, my friend. And thank you. You are a great person. You are the head of Dacrylology Society, isn't it? British Dacrylology Society. Or you are the founder of Dacrylology?
I was one of the founders of the British Oculoplastic Surgery Society, and I'm currently the president of the International Society of Dacrylology and Dry Eye.
I see.
And we're going to be having a meeting in London either next June or October. We're just looking for the venue at the moment, so we'll be posting you about that in the future.
Fine. Please add me to your
Certainly
Dacrylology
will.
Society. Thank
Yes.
you. Thank
Yes.
you. I'll be great. Okay.
Also,
Thank you,
also
everyone.
admin.
Okay, please. Okay. And every one of these very, very nice panelists, speakers. Thank you, everyone. Thank you. I have enjoyed really being
Thank
with
you very much, Mahmoud, for the kind
Much.
invitation.
Not at all. You're welcome. Okay. Thank you, Dr. Muayin. Hi.
Have a good
مع
evening.
السلامة. مع السلامة. شكرا. Thank you, Dr. محمد العمري, if he is around. Okay. مع السلامة. شكرا, Dr. ثابت. مع السلامة.
مع السلامة. شكرا.
مع السلامة. أهلين. تحياتي.
مع السلامة. شكرا جزيلا.
مع السلامة. شكرا لك. شكرا. We have maybe more than 150 maybe participant at one occasion or so forth.
180, I
Thank
think
you.
that's all 180 at
180.
one time.
It's a great thing. Great. Thank you. Thank you.
Thank you very
Okay.
much.
Thank you. Okay. Bye. Thank you.
Bye.
مع
Okay,
السلامة.
bye.
مع السلامة. مع السلامة.